Hi guys, this is group 4 with group counseling and mutual support with Misty Cox, Hope Orozco, and myself. Okay, let's get started. So group counseling is a method of therapy that consists of a limited number of members who all suffer from the same condition. This is used in, I want to say, most, if not all, of RTCs, IOPs, and different areas of treatment. The purpose is to use resources and experiences of a group to learn new behaviors and recognize, confront, correctly label, and deal with the client's denial and unpleasant feelings about his or her addiction. I think we have, from my own personal experience, we run at least 2 groups a day in the RTC, every day on the weekdays. Let's go to the next slide. So for mutual support versus group counseling, there are a lot of differences. Both methods are effective for producing change. However, they demand it in very different ways. The picture shows the different ways of therapy and support. Next slide. Okay, guys, for constructing a group, it's essential that people are in the group are there for the same reason. Not everyone is going to benefit from group therapy, and not everyone will contribute to a group during therapy. Group counseling is not ideal for every client or for every situation, but there are, however, many clients thrive in group dynamics and need daily reassurance that they are not alone in the isolation. Group therapy kind of makes it okay for individuals to have the same problem, more or less. The group leader must have a clear concept of the type of group to be formed. Group leaders must emphasize the importance of maintaining confidentiality. So whatever's said in group can't be talked about outside of group. And it's very important that we maintain that for client integrity and for us keeping our ethical integrity. Let's go to the next slide. So there are 2 stages for group counseling. The first stage is developing, right? So in the developing stage, norms and relative positions among the various group members are established. This is just the beginning. So when we're trying to facilitate a group, bringing everybody together. So there's different sub-stages. The acquaintance stage is the rough part. So in the beginning, group members are uncomfortable, right? Because they don't know anybody. They don't know each other. They don't know each other's stories. And it's heavily dependent on the group leader to be able to set that standard. The groundwork stage is usually when there's a lot of conflict. And that can be with like kind of the hierarchy, like listening to the group leader. There can be different peers in the group that are having conflict. But that is an important stage where the group leader needs to take control and to be able to facilitate the group in a healthy way. The second stage is the potency stage. In the potency stage, the authority issues have largely been resolved. Group members no longer rely solely on relative positions in the group. So what this means is, by this time, everybody's pretty comfortable with each other. Everyone knows the role of who the leader is, and respects that. So the working stage is where everything gets done. This is also called the feel-good stage of the group, where most of the work gets done and everybody is content with the group. Occasionally, participants will want to stop to celebrate and stop working at this point. So the leader must be sensitive to developments that will lead to group away from the task. And then the last sub-stage is the closing sub-stage. A lot of groups don't reach this final stage. Members do not feel bound to the group as they did, but each is capable of taking risk and giving feedback in a productive manner. So the last part I want to share with you guys was the stages of group development. This was developed by Bruce Tuckman in the 1960s. As you can see, there are 5 stages. The forming, the coming together for group development, the storming, a chaotic of leadership and group processes. This is kind of like the last substage that we were talking about. Norming, group agrees on norms and agrees how group operates. That's like the working stage, right? Performing, practices its craft and becomes effective in meetings. And then adjourning, process of uniforming the group. So now I'm going to turn it over to Hope to talk about mutual support.
Mutual support groups are alternatives to professional counseling, where ordinary clients meet to discuss similar struggles. Mutual support programs are based on the assumption that change can result from a group of people sharing their common conditions, experiences, and beliefs. People are encouraged to identify with the emotions of the other members. This commonality to motivate them to change their behavior. The first publicly recognized mutual support program was created in the mid-1930s by Bill Wilson and Bob Smith. The group is now famously known as AA, or Alcoholics Anonymous. AA utilizes the common experiences of its members at a 12-step process and spirituality to combat alcoholism. Another important element is that AA believes that the addiction is a disease that it can never be cured. The only way to live alcohol-free, according to AA, is to surrender oneself to a higher being and accept that he or she is powerless. Mutual support groups are voluntary, so controlled studies are impossible. Participants do not equally represent the population and are generally middle class and are conservative. Participants usually suffer from mild dysfunction instead of extreme dependence. The group leader is usually not trained or certified in the topic area. Some key words that we should focus on for mutual support groups or programs are: qualifying is when a member shares his or her personal experience of an addiction with the group. Open meeting is sessions of Alcoholics Anonymous that are open to the general public. Closed meetings are members only. Sessions of Alcoholics Anonymous that are not generally open to the public. Sponsor, a mentor in Alcoholics Anonymous to guide a member through the 12-step process. And then a Rational Recovery, or RR, is a mutually support program and alternative to Alcoholics Anonymous that emphasizes personal control over behavior and eliminating irrational beliefs.
Hi everyone, welcome to the case study portion of our presentation. Below we have just a simple abbreviated version. If you would like the full case study, check out the attached PDF that includes more of the detailed information that went into our diagnosis and treatment plan. We did this to minimize the information on the slide, as well as give those who, like myself, who like to go back and read the case study, we gave this as a resource to be able to do that. So please, in your comments before you mentioned there wasn't enough information in the case study, please check out the PDF first. So in this study, we have a 28-year-old male graphic designer who is living in an urban city. So right now, or he appears on the surface like a typical successful male. However, he's battling an opioid use disorder. He was in a car accident 3 years ago and was prescribed opioids to manage that pain. His tolerance for the opioids increased, thus creating a need for more to control the chronic pain that he was in. However, like all prescriptions do, it ran out. His life began to really spiral and unravel as he turned to shady dealers to obtain his drugs. He spent a lot of energy anxiously calculating his doses and living in fear that he was going to run out. Dynamics with his family have been impacted by his secretive opioid use. For Alex, the pressure to maintain a facade of normalcy has become crushing. Additionally, Alex recently experienced the loss of his younger sister due to a sudden illness. Now he is using opioids not only for pain, but to escape his growing feelings of guilt, shame, sadness, and grief. Here's the treatment breakdown plan that we have for Alex. First, in acknowledging some of the risk factors that are involved with Alex right now, one, he is grieving the loss of his sister. He has chronic back pain that has been difficult to manage. There is a lack of support from family, and mostly due to his unwillingness to communicate with them and share with them the challenges that he's facing. And lastly, he's getting involved in some really risky environments when associating with drug dealers to obtain what he's wanting. Our diagnosis is opioid use disorder. It meets the DSM code F11.20. The criteria that are met include increased tolerance, he's had withdrawal symptoms, unsuccessful attempts to stop, and significant impairment in functioning and ability to be productive in his life. The level of care that we're initially recommending is 3.7 due to his need to be medically monitored for his detox period. However, upon detoxification, we're recommending a transition to a level 3.1 residential treatment center for regular OUD support in a structured setting. Lastly, the interventions we are recommending include basic CBT for addressing unhelpful thought patterns and encouraging coping strategies, especially around the loss of his sister. With that, we also recommend grief counseling, and this will allow him the ability to process all of the feelings and emotions, the grief and the loss associated with the passing of his sister. All right, here are some questions to consider. So when understanding family dynamics and support, how can family dynamics contribute to the development and maintenance of substance use disorders? In Alex's case, what potential strategies could be implemented to improve his communication with his family and be able to get the support from them that is needed? The role of grief in substance use. How can counselors effectively address grief in clients like Alex who are struggling with substance use disorders? What specific interventions would you consider? Lastly, therapeutic interventions. Considering the therapeutic interventions that have already been suggested for Alex, like CBT and grief counseling, what do you believe would be most effective in these early stages of treatment and why? So this just gives you a basic outline of questions to consider as you're writing your responses. We want to thank everyone for watching our presentation, and don't forget to check out the PDF for the full detailed information of Alex's case study. Here are a list of the references we used. We hope you have enjoyed this presentation, and good luck in the discussion boards. Thanks.